we're going to have about 3 minutes for discussion. The trending topic on the chat board right now is, let me address this to both Dr. Conrad and Dr. Arghetti. What are your thoughts regarding the role of ICG in the future relative to intraoperative ultrasound? Where do you think that's going to go? Is it an absolute necessity? It seems that way to me, but I'd like to hear your opinions on it. Thank you.
Yeah, this is Claudius. So I think they are complementary techniques. Ultrasound is mainly spatial and anatomic information, while ICG can give you anatomic and functional information. So I think as we are becoming more anatomic, yet more parenchymal sparing, ICG will become more and more important. I think the future will lie into integration of ICG into more advanced imaging, such as 3D monitoring, having a flexible tip camera, and I think that's where the future is heading.
Thank you. Dr. Arghetti?
Yeah, I'm Dr. Chen, Yajin Chen from China. I have a question for Conrad. When you do the laparoscopic liver surgery, do you routinely use control row CVP?
I'm sorry, do I typically control the CVP?
Yeah.
Yes, one of the most important aspects of surgery for the liver is to have a dedicated anesthesia team to liver surgery. And that control becomes more and more complex as you're doing laparoscopic rather than open surgery. So yes, we control the CVP not only with low volume anesthesia, but also with the intrathoracic pressure, with the pneumoperitoneum, and we actively manage it throughout the entirety of the case. I think it's a tremendously important aspect of all laparoscopic liver surgery.
So let me follow up on that, Dr. Conrad. So for those of us that were trained by Blumgart, we typically use the Melendez technique, which was, 0 to 5, but we usually kind of go to 3. Watching your video, that was closer to 0. How do you train your anesthesia team? How do you communicate? Because that's always the hard part.
Yeah, this is an excellent question. And I think your answer lies already within your question. It's about communication. If you just show up in the OR and hope everything is going to be okay, you will probably be surprised. So it is important to form a dedicated team. We have liver anesthesiologists who preferentially come to our case. They train their residents who love being in those cases and actively manage the central venous pressure, but it comes down to communication.
Professor Arghetti, your thoughts?
Well, I think ECG is the only way to do a real anatomical resections, because so far we think we do anatomical resection, but we just look at the surface of the liver. With the ECG, it's possible to do transection looking at the staining inside the liver. So that's the real difference. And this is absolutely new, and this was never done before. As for the volemia, we don't use CVP anymore. We prefer stroke volume variation because we think it's more reliable, and we actually did a couple of studies on that, reducing the rate of bleeding and curvation for bleeding by using the stroke volume variation. But the concept is the same.
Thank you. So we're going to move on to the next session, which is sponsored by AngioDynamics. And let me introduce Dr. Chen, Professor Chen from Sunchi China, whom I didn't get a chance to introduce earlier on. Dr. Chen, welcome. Let's proceed to the next series, the AngioDynamics, please.